I'm very glad to be here for many reasons, except apart from the warmth and the friendship. I'm happy to be in one of those few pockets somewhere in the globe where communities are gradually recognizing the value, its own value of being communities. Somehow over a particularly over the last century, but particularly over the last half century, the communities all over the world seem to be breaking up, and we are becoming more and more nuclear, contained in small pockets without any relationship with the external world except through the television screen. And that has numerous consequences, of course, on the health of the individual as a whole. And I believe by encouraging community participation in healthcare, we palliative care people are doing something more than compassionate care in the presence of diseases. I believe we are doing more than healthcare in the community. I think we are creating a different world, a world full of friendship and compassion. Uh, if we were having only three palliative care centers with involvement of the community, I would not have been courageous enough to say this, but I have seen how communities grow and how they have grown across a whole state in India, and I am really hopeful for the future. But before I start, let me thank my friends Mike Hill and Sue Hill, who created the movie The Hippocratic, who have been doing palliative care movies one after another. This is their fourth movie with the theme of palliative care. With they find it hard to find funds to create these movies, but they are doing this for global advocacy for palliative care. They have the reason why I could be here with you today, and I thank them. I also, he was very happy with the outcome of the screening yesterday when I informed him and wanted me to convey to you that anybody who wants to obtain the movie, of course, we still have discs available for sale, but online purchase is possible, and anybody who wants to pick up a couple of the cards so that you can access the movie will be welcome too. I'll leave them here. Let me tell you a little bit about the background in India where I work. There are a lot of us, 1.25 billion plus and growing fast, 1/6 of the world's population. The good news is that many things are improving. GDP is improving, but the inequity in wealth is also increasing. The rich are becoming very rich, and with the amount of wealth we have in the country, I am ashamed to say that we still have 1/3 of our population living below the international poverty line. Maternal mortality is declining, infant mortality is declining, almost on par with USA now. That's great. But the suffering, health related suffering, is also increasing, unfortunately. Pain doesn't get treated, palliative care is available despite all our efforts for a quarter of a century for less than 2% of our population. Unfortunately, that's not only India. You'll find it hard to believe that is a story for 85% of the global population. Many of you have worked abroad, you have worked in Africa, some have worked in Nepal, in some countries, but including those pockets, the people who have access to palliative care still remains less than 50% of the global population. That's the sad part. In my own country, our National Crime Records Bureau report that every year more than 26,000 people commit suicide for health related reasons alone. That is not only pain and suffering, it is also financial destruction. Again, some of you may be surprised to learn that except in that 15% of the global population, treatment costs are mostly out of pocket. If I fall ill, it's Chandriya's responsibility to find enough money. They will ask for this scan and that scan and this intervention and that intervention, and families get wiped out. The next generation also gets destroyed. This car that you see on the screen is not a very unfamiliar sight to me. This particular man had numerous investigations, and they thought they would operate on him. It was not cancer in his case, it was a peripheral vascular disease. His blood vessel had got blocked. The pain was so agonizing that he tried to hang himself. In his struggle, he kicked the tall stool that he stood on to hang himself from the ceiling. His two children, something like 12 and 9 years each, heard the noise, came rushing in, picked him up and lifted him up and saved his life. They screamed and neighbors came and brought him down. One of the most painful things that I've ever seen in my life, in my palliative care work, was the sight of the man actually touching the feet of the children and begging for forgiveness. Because he realized what trauma he had caused to him, and those children must still be living with those scars because the man died anyway. You know why? He did not get opioids. He went on taking non-steroidal anti-inflammatory drugs, so that his kidney got destroyed and he died of renal failure. No, these are stories that happen all over the world, or 85% of the world. We come to your country and learn all the technology. We take back the machines. Great things. They are very shiny with all those lighted bulbs glittering all over the place. We love technology. We take them back. We don't take back your social workers. We use those machines to cure a lot of people, I am happy to say. But we use those machines also to inflict suffering on a lot of people. And that's happening all over the developing world. And paradoxically, because of that, very paradoxically, the poor seem to die better. I may not spend the time to tell the story of the elderly woman, but that woman who was living in an orphanage, in a poor home, at least got her daughter with her for the last 5 days. She had some drops of water down her throat when her throat was parched, and she died with the daughter's hand on the forehead of the woman. But everybody who has some money in the pocket, like that man there, gets imprisoned in an intensive care unit, even if it's advanced cancer or any incurable disease. The medical system considers it duty to keep having the heart beating indefinitely as much as possible, at an enormous financial and emotional and social cost to the patient and family. And by the time the man goes, the rich family has become a poor family. This definition, almost as old as myself, still holds true. Nobody has challenged this. Health is not only absence of disease. It is physical, social and mental well-being. Can I interrupt my talk to request you to think for a minute? Is the global healthcare system actually trying to deliver this? Would anybody have a response to that? Many of you are healthcare professionals. Are we giving healthcare? Not, I am not asking the palliative care people here. I am asking about the global healthcare system. As a healthcare person, I am asking myself, is the global healthcare system actually delivering this? What do you think? Yes.
No, of course not. So, any healthcare provider basically is concerned with the diagnosis of the disease or the illness and how to come into a definitive diagnosis by running lab, blood work and investigations, and then giving the treatment, which is in the form of medications. That's it.
But why? I mean, we have this definition.
Yeah.
We call ourselves healthcare people. Why are we not trying to deliver this? What could be the possible reason?
We were not trained. I'm a medical doctor, and I was not trained to look after the social well-being of my patients. So, I'm trained. I was trained to just treat the disease, the illness. That's it.
Isn't that strange?
Yeah.
Now, could that be because doing what you described is simply convenient for us, for the healthcare system, to use the machines to diagnose, to do interventions, to give medicines, write prescriptions? That's convenient. Maybe going into the social, emotional, or spiritual issues is not convenient and not measurable. We like measurable things. We like things that we can weigh on a scale and measure out in milligrams and dispense. Love is not easily measurable. And compassion is not easily measurable. And we have so far avoided that. Yes, doctor.
Going into the mental and social well-being of people just doesn't pay in our system. And that's a real problem.
Or in any system, doctor, if the doctor spends 2 hours performing an operation, imagine how much the person can be billed. 2 hours of sitting there and holding a hand and listening. How much can you ask the person to pay?
Very little.
Very little.
Yeah.
So essentially, we healthcare system is doing what is convenient for us and what is profitable for us. And maybe not thinking as healthcare professionals, but thinking as tomorrow's patients and thinking of as family members of tomorrow's patients, we need to ask ourselves, shouldn't we be demanding a little more, or shouldn't we be trying to create a system that's a little more responsible? Because what we are doing is sheer irresponsibility.
Absolutely.
Sorry, Doris, you heard this story once already. The young woman had advanced cancer of the breast. She had severe pain, and every time she took morphine, the pain would subside. But the home visit team never found her pain-free because she was very irregular with medicines. Her husband was in the army. He was terrified of the husband who would come home only for 1 month every year. She had 2 small kids. They were being taken care of her sister-in-law. And I was asked to see her because she was so much in pain. I mean, she was rather very defensive. Many people had been lecturing her about taking morphine every 4 hours. So when I sat down beside her and said, if you are not taking the medicines 4 hourly, there must be a very good reason. Tell me what it is. She first said, it upsets my tummy. It gives me constipation. But then I pointed out that, okay, you had the tummy upset first when you took the ibuprofen, not this. And the constipation was relieved when you took the laxative. So maybe there is something more. He said, 4 hourly, I can't tell the time, I don't have a watch. So I said, there is a clock in the living room. Let me bring it up or down and hang it in front of you. I don't like looking at the clock. I asked, why is it that you don't like looking at the clock? And she said, the clock tells me that time is passing. And then all the story came out. Her fear of death, fear of leaving the children alone, the fear of the husband remarrying, and a stepmother being cruel to the kids. At the same time, upset that the children were getting attached more to the sister-in-law than to her. All these conflicting emotions were troubling her. A lot of conversation later, it also came out that she had, as a teenager, once attempted suicide by jumping into a well. And then it was brought out that she had suffered from clinical depression off and on. All these things came out, and that is the kind of total pain that Cicely Saunders talked all about a long time back. And I am quite convinced that if our healthcare team continued to be what it was a few years back, with 4 doctors, 12 nurses, and 1 medical social worker, we would have got nowhere. We are able to take care of these things at least up to a point, nowhere near adequate, but at least up to a point, because we encouraged lay members of the community to come into our team and help out. This statement was by a rather famous psychiatrist. What do you think about that statement? And I'm taking a liberty with that and modifying it a little bit. Why only mental? Health as a whole. If health is that kind of well-being, how can it be just delivered by the healthcare system? It has to be a partnership between us and the patient and family, if possible expanded into the community around them. This brings me to the concept of social capital. Let me take a liberty with that definition and say that social capital is the essence of goodness in the community. Many of you have been to many countries. Can you tell me any place anywhere in the globe where there wouldn't be a few compassionate people who get sheer pleasure out of helping someone else? I am a stranger to your country. When I go out by myself, so far I have had Doris holding my arm, but when I go out myself and ask for directions, I find people are so helpful. They are so keen. They see that there is this strange kind of being lost somewhere. They make sure that I get the right direction. That intrinsic goodness is still there in most people. We are just giving people the privilege of finding meaning in their own lives. Young school children, college students, and retired people, they all want something that gives them more meaning than just studying textbooks and regurgitating at the exam, or just now retired life, relaxed life. After 1 week, they have had enough of relaxation. They want something to do with their time. And we are giving them the privilege of making meaning out of their lives. Now, the problem with the micro element of today's social capital, all the goodness is within the nuclear family, which has less and less connection with the community around them. And the hospitals are now becoming bigger and bigger and more corporate. huge palaces. She is a total stranger there. In my state of Kerala, that is deep south of India, tiny state, what we did was to rebuild the meso element of the social capital, allowing the community to come in and help. The connection between the corporate system or the government's hospitals and the nuclear families, reconnecting them. Let me expand that middle picture. 2016, second Saturday of October, World Palliative Care Day. Our team decided to give a treat to the paraplegics that we care for. By the way, in your country, paraplegia doesn't come under the purview of palliative care, I suppose, because they are rehabilitated, they are part of society. In my world, that is 85% of the world, paraplegia is a life-threatening disease, threatened by pressure sores, septicemia, repeated urinary infections, and life within four walls. Homes are not barrier-free, roads are not barrier-free, supermarkets are not barrier-free. They are unable to go out. To get these people to the seaside for a treat, each needed 4 volunteers. About nearly 50 people got together on wheelchair. Each needed 4 strong men to pick them up, physically seated on a chair, carry them to a road, because most of them do not have road access, and then bring them here. So about 150 students came, and you should have seen the glow on their faces. And that perhaps was the most meaningful day of their lives also. And what it meant to these people, that girl in red and green, second from that side, she does not have normal sensation in her feet. And she said, the waves touching my feet was the best experience that I have had in my whole life. Is that healthcare? Giving her that experience? Going back to that definition? And could we doctors and nurses alone have ever given that kind of healthcare at its depth? This kind of thinking from their point of view and providing more than what the hospital or the institution can give is what we achieve by engaging the community. Unfortunately, though there are good people everywhere, the community does not get together to form healthcare. And you asked me this morning, what advice would you give them to get engaged in healthcare? And my response still is, it cannot be done by giving them advice. The change has to come from us, because healthcare is an intimidating field to any non-medical person. How can they even dare to step in where we use words this long, no diagnosis pronounceable even, and the machines are so intimidating? How will they ever dare to enter our field unless we invite them? What we do is, wherever we can get a few people to listen, we do awareness programs. We have one social worker assisted by a few volunteers who do only this. They run awareness programs. Almost invariably, 2 or 3 people said, how can we help? Can we become volunteers? We get them to meet, and when there are enough people, we do volunteers training program. They need some information about what they can do and what they should not do. We facilitate that. Even simple things including hand washing, about how to listen, about how not to talk, about how not to inflict one's personal convictions and beliefs on the hapless patients. These things are taught and understood. We encourage each group to form an organization. So in that locality, if it is 12th Street residents, they form their own organization. We found that to be very useful after the first few years, because then now they have an organization that they can take ownership about. And I believe that is important for sustainability. They are not our branches, they are our partners. The organization or the group belongs to themselves. Sometimes, when they are large enough, we encourage them to formally register as a charitable organization to improve accountability. But we continue to do the hand holding. Very often, they do not have all that they need. They will need professional advice, and that has to be provided by us. But eventually, some of them develop their own professional support system. I know of, even in Trivandrum, where I work, 2 organizations have employed now professionals. One has employed a doctor part-time and a nurse full-time. Another has employed a nurse full-time. And they develop this so that they are able to do more and more in their community, so that we do not have to provide all the support all the time. And because these volunteers are engaged, many things happen. Like that woman following a hip surgery, like many people undergoing surgery would have been bedridden because there is no effective rehabilitation program. A volunteer went to her almost every day for 3 weeks and would say, "Amma, come, get up, let us walk a little, let me walk with you." Encourage her to exercise, to walk, and finally got her back on her feet. We doctors and nurses couldn't have done that alone. And the volunteers help us to find the needy patients. They tell us somebody has become ill and there is nobody to look after them. And this woman in that hut possibly would have never seen a doctor if we had not reached there. And we wouldn't have reached there without the volunteers in the community. She gets a home visit every week by our team. They take medicines with them and dispense them and make sure that her condition within that humble home is as good as possible. And because we have the volunteers, we are able to do adequate education of families. One of the fortunate things in our environment is that though it is dwindling, generally there is still a family structure. Patients usually are not left alone. There are people helping them. And the volunteers and our team teach them and make them part of the system. With the result that from some of those families, those who gained a lot of palliative care experience by nursing a mother or a father or a spouse, they themselves become strong volunteers for the future. And because the volunteers are involved, we are able to do some things. Like palliative care is improving quality of life for the patient and the family, not forgetting the children. We found that in a lot of homes, because of the financial destruction by treatment, children drop out of school. And we make sure that children's education is supported. We now look after the education of more than 300 children. We have had a doctor passing out from that group, several nurses, engineers, and others to get an earning capacity for the family. It is not only helping that child, it's helping the whole family. And when we go back, the very next day, we'll be participating in their annual summer camp, where children from high school will be brought together for a 3-day stay there with some fun, some learning, and some interaction, making new friends, and getting exposure to the world more than a little that they are confined to in their own homes. And by doing all this, I believe that certainly we are helping patients and families, but it's also helping ourselves. All the healthcare workers are now getting more satisfaction out of their work. We often talk about burnout of doctors. I don't know how common that's in palliative care in this country, but we generally find that professionals and volunteers get a lot of satisfaction from their work simply because we are no longer running away from suffering. We are facing suffering. We now have the capacity to do something about it, and that gives us better morale. That's my feeling. Our organization, Palliative India, tries to do this all over the country. We find pioneers, champions who are keen, and help them to build capacity and to keep on helping others. But I can also tell you, the other elements of our work are easier, but getting doctors to accept community involvement is harder. They are not used to it, and hospitals are generally not very keen on it, and that paradigm shift comes much slower. Looking on the bright side, we have had some successes. The National Program for Palliative Care created by the Government of India does at least profess to engage the community. That is as one of the six objectives of the program. We have got the law governing opioids changed in 2014 so that access to opioids for pain relief is easier now. We have got the medical council to accept palliative medicine as a specialty, though we have not been successful in introducing palliative care into undergraduate medical and nursing education yet. In my own state of Kerala, the government has a palliative care policy so that every primary health center now has at least one nurse with training in palliative care, working full-time in palliative care. But then my state is only 3% of India's population. Much of the work was supported because in 2008 we went to the Supreme Court with a public interest litigation. That could have been a double-edged sword, but we tried to explain to the officials it is not a conflict, it's a conciliatory public interest litigation, it's a facilitatory thing, etc. Somehow we managed, and that helped many of the governmental changes. Though I mention it last, we see it as our major focus for the future. Because we know that healthcare is a partnership between the person and the family and the medical system, improving public awareness is the key to development of further compassionate healthcare and palliative care in the future. And that we have been doing it amateurishly. We need to build the capacity and do advocacy more effectively and efficiently. I shall stop there. Thank you with very great gratitude to all of you for listening to me patiently, and also with gratitude for what you are doing to build compassionate communities here in Canada. That's my email ID, and I hope we can continue to work together, because I find that I have so much to learn from what you do here. Thank you all very much. Thank you.
Thank you for sharing your work and your perspective. You mentioned sort of the physical barriers to people being fully included in their communities, mentioning that homes are not always accessible. Is there any work being done to reduce some of those physical barriers to people's full participation?
Yes, I'm glad that there's some considerable work going on, but I'm afraid it's not enough. One of the things that happened in 2017 was the Indian Parliament passing a law making it mandatory for public establishments to be barrier-free, but that at the moment remains a paper tiger. There is no clear plan of action for its implementation. So I have working with me my executive assistant is also an activist. She's a quadriplegic. Her name is Ashla. She has been spearheading a movement from our side, and there are many activists in the country trying to advocate for this. But that is not convenient again for the engineers, for the government. It's easier to ignore them. So there is considerable advocacy needed there. We get together with international agencies, and the person that I mentioned just now was in California 2 weeks back, having discussions with B.J. Miller, whom you might have heard about, and another activist there, and trying to develop a strategy. But you seem to be interested in that, and I would certainly would like to leave my contact with you and be in touch, so that that group working in the country needs a lot of support.
Thank you again. Medicine used to be a calling, and now it's a job. And I think I'm speaking for North America now. In India, I think there's a much stronger, cohesive family unit that can support some of the kinds of things that are important to palliative patients. But in North America, I don't think that exists nearly to the same degree. So how do you feel that cultural shift that needs to take place in terms of focus, both in the medical profession so that patients become more important than a 4 o'clock tee-off time, and so that people get more joy out of treating people and making their lives better? How do you think that cultural shift can take place?
If I may talk about two different aspects of the issue. One, about the family unit and its strength. Unfortunately, one negative aspect of our global development is urbanization and globalization. Young people going away to find jobs elsewhere is a reality. I don't see it changing, and I have no idea about, I don't know enough of that science of sociology or anthropology to find an answer to that. So that's a reality, and the answer to that can only be further strengthening of local communities, even if not necessarily related by blood, purely bonded by love and affection. That kind of building of communities, I believe, is still possible. But there is another big question there, and for which I look to you all for possible answers. When I talk to medical students, I don't know, even in this country, not in Canada, but in USA, I spoke at several universities. Young doctors and medical students and nursing students are not very clear about what their function is. They still, if asked, they do not say, our duty is to relieve suffering. They do not say, our duty is to improve quality of life. They are confused. I think there needs to be a concerted effort at one global statement where the healthcare system accepts that while treating diseases, they also have a duty to address serious health-related suffering. There was a Lancet Commission report that came out in 2017 October, which talks about serious health-related suffering as the possible focus of healthcare, which identifies that 60-odd million people all over the globe are in unrelieved serious health-related suffering. So what will we do to make the World Health Organization and all bodies and all textbooks of medicine and nursing to proclaim that the healthcare professional has a duty, primary duty, to address health-related suffering. Can that change happen? What do we do to make that happen? A lot of people talking about it, on social media, tweeting about it, forcing somebody to address the issue. A global commission to look at serious health-related suffering and to develop a strategy for addressing it. I'm not sure, but I do know that that revolution is necessary.
So anyone else? Thanks.
Thank you so much to you and your wife,
Thank you, Celia.
to the wonderful gift that you are to the whole world. And I'm really touched today and last night by how much you see the dignity of the person. We're not just human doings, we're human beings first. And you're able to connect and help people experience that it's good that they exist, and so they can find hope in their situation. So just want to thank you for that.
Thank you, Cecilia. Thank you. And your eyes filled, and that's a gift to the world. That's the compassion that you are giving out to the world. Thank you for that.
Anyone else? I'll just get the mic.
I hope some of the comments also will bring out more ideas about that change in focus of the healthcare system towards suffering.
Thank you very much. I surely can't talk the last comment and the emotions that speak, but I'm a researcher primarily, and I work with clinician researchers, patients, and government officials in trying to bring research evidence to change the system. But I'm particularly impressed with the way you have mobilized the volunteer power amongst our communities. We try to do that here, and I think what we have done is quite different from your approach, and I'd like to hear a couple of words about what we go with organizations that are there and they have volunteers and work with them. I'm doing a project that didn't go that way, and I'm looking at former patients in cancer to become volunteers helping the new patients in cancer. So but it's still a sort of North American model. But I heard you say you are going and working with college students and retired people, and the way you explain that to the point of creating their own organization eventually as the groups. But that takes enormous amounts of perseverance, dedication, and actually quite a bit of groundwork to get to that point. If you could just tell us how you actually mobilize that kind of power, I would be really delighted to hear your thoughts about it.
Thank you. I agree that it takes a lot of effort, but I must also tell you that to build a community group requires less effort than installing an MRI machine. It does take time, it does take effort, but not unachievable amount of time. If we decide that our time is well spent trying to build that, and that group may eventually make more difference than that additional MRI machine. I'm not underplaying the value of technology, but I am trying to say that sometimes we should set our priorities. Once we consider it important, maybe there will be ways, but we need to be cautious. There are several issues there. I would be happy to share with you a paper on social capital, that a publication from USA that I have seen, And they caution against some of the negatives there. And I have seen some of this happening in Kerala. Palliative care with the volunteer participation has become so popular that people see opportunities. Now vested interests will come in. One, political. Actually in Kerala, a political party has declared palliative care as their agenda. And they are training their own party members as volunteers. That's great. That can be fantastic if their primary objective is the welfare of the patient. But if their primary objective is growth of the party, then maybe that will become a part of the problem and not a solution. Similarly, religious fundamentalist views, they come in. I have seen that happen. Because very often we work with all three major religions in Kerala. Palliative care organizations are there in Hindu, Christian and Muslim groups, and most of them do fantastic jobs. I mean, none confines their service only to people of their religion. They don't discriminate, they give care to everybody. But there are a few who have fundamentalist ideas and want to inflict this, push that down people's throats. And somehow, if they can convert somebody in the last week of life, they consider their job well spent, not considering the amount of social suffering that causes even within that person. Sometimes it gives them peace, but sometimes it causes great conflict. And I've seen that personally. So these vested interests will come in. That's one. Secondly, you are encouraging them to come to even to the hospitals. We are. Into our establishment, they are welcome to. They are not welcome to the corporate hospitals. People are saying, come, let us help. And the hospital says no, because they are not convenient. They will ask questions. They will be the patient's advocates. You can't make them mute. They have the passion in them. They will be advocates, and that can be inconvenient. So these things we'll have to take into consideration. Some ground rules will have to be accepted. Those who are not willing to go by the ground rules cannot become part of the system. But it takes effort, I agree. Can I take that question, or is that?
All right, one more question. Sorry, where was this?
I just wanted to comment on your question about how do we globally get together to encourage relief of suffering. So I think the relief of suffering, the obstacles, a function of economics. The financial model of the healthcare system in Canada does not allow for the time that is required to address the issues related to suffering. And so using social capital harnesses that time from the community, which is valuable, a very, very valuable resource. And it's the time that is required to start addressing suffering.
Thank you, thank you. I mean, building that, making that economic model and presenting it as a case, I suppose can be valuable. Thank you.
I'm sorry, but we're going to have to draw this session to a close. We are on a limited time so that Dr. Rajagopal and Chandrika can head off. But I thank you both for being here with us for the past, well, in BC for the past few days. And it truly has been our privilege to hear about the work that you're doing in India, to be inspired by it. And I think the evidence is here that you've touched on the deep sense we all have of compassion for another human being and how that can be used to make life better for all of those who are living with a serious illness and at the end of their lives. So thank you so much for being with us.